Uh, Perianal and anal sepsis, in our terminology, pretty much means the same condition. As you can see from the word sepsis, it is infectious condition that is located around the anus and around the anal sphincter. Nowadays, across our surgical community, is accepted something what is called cryptoglandular etiology, which is the explanation why this sepsis happen. For just a brief explanation, all of us, we have glands in our back passage, which these glands are sitting just above the sphincter of the ring of anal sphincter, and the role of these glands are to produce the slime. These glands on occasions can get infected. We know that it is a relatively common condition. However, most of the patients or most of the people don't even have to have any symptoms, and that is a condition that resolves spontaneously. However, unfortunately, on some occasions when this gland gets infected and the pus and infections start to get collected with this gland, what happens is that this opening of the gland into back passage gets swollen, which means blocked. And then our immune system is trying to get rid of this infection, and therefore that infection is spreading the direction of the least resistance, that unfortunately means towards the skin and soft tissue that is sitting around the back passage. As a result of it, patients traditionally develop the condition, which is usually called as a boil. We call it abscess, and that is a collection of the pus that is sitting next to the back passage, just underneath the skin. Sometimes even this condition can spontaneously get perforated. And of course, in the bad option, that is the condition that has to be managed by the fairly minimal surgical case. That means the patient needs to be put asleep, and this pus needs to be evacuated. Unfortunately, what happens is that the infection or the sepsis is released, and therefore that originally swollen internal opening of the gland just get reopened. And unfortunately, by surgery and reopening of the gland, that develops the, in fact, bypass communication that is bypassing or going through the ring of the anal sphincter, and that is the definition of the fistula. Symptoms of perianal sepsis can vary in terms of the frequency, intensity, and nature. The classic development of the anal fistula is sudden onset of perianal pain, progressively increasing redness, hardness, and again intense pain. Patients can have the symptoms of overall generalized sepsis, which means shivers, malaise, being overall unwell, risen temperature. On occasions, these symptoms, they don't have to be this dramatic. Patients living with a chronic fistula can have just a continuous pussy or bloody discharges, which again quite naturally is accompanied with the discomfort. Unfortunately, this chronic condition we see quite common. Patients can have these symptoms for even years, and they live this way because this is quite a delicate location of our body, and therefore patients sometimes are very reluctant to see either GP or specialist. Perianal sepsis is a condition that sometimes can be just simply visible on just the inspection in a way of, due to the classical symptoms of the redness of the bulging on the surface. So clearly it is a condition very simple to diagnose. Of course, surgeons should go ahead with the rectal examination, which, if possible, sometimes not, because again that condition is very painful, to confirm the fluctuation or the collection sitting next to the passage. Nowadays, in terms of the investigations, we still more and more often use the MRI scan, which is by its nature is a no harm scan, which is very accurate and that can tell us far much more details in terms of the size, location, shape, and of course based on that MRI scan we can then easily tailor the treatment as such. The other test is the called end-to-end ultrasound. That is a very detailed and very small ultrasound probe that investigates the ring of the anal sphincter, and that is a test, as we can imagine, it's not exactly pleasant. However, it can pick up even smaller collection of pus around 1 or 2, even 1 or 2 millimeters. Unfortunately, this condition can have a variety of complications. Truth is that unfortunately, by nature, by definition, this is the infectious septic condition that requires, in most occasions, surgical intervention, and then we are trying to heal this wound in the most infectious part of the human body, which is the situation that even now still we as a surgeons don't have the treatment that would have and that we could offer to our patients 100% success. Complications, it is a sepsis, so if not recognized, if not treated properly, in the rare conditions, it can be really very serious and a very dangerous condition that can develop into really the generalized severe sepsis. So that is something definitely would be most fearful. If these sepsis or fistulae last for long, in terms of the decades, that chronic infection can irritate the tissue involved to the point that structural changes can start to develop, and in a rare condition, after decades of this unnatural irritation by inflammation process, the tissue can switch slowly into changes, even to precancerous or even cancerous conditions. So when we operate in patients with the fistulae, part of whichever kind of the operation should be taking the biopsies and of course making sure that we are not missing any serious condition. Other complication which is possible, but we don't see very often, is that function of anal sphincter in terms of the continency can be affected to different extent. We see patients who suffer from these fistulae for years, and as I said, some are reluctant to have the treatment or to go to GP or surgeons. When these conditions last long or have several episodes of the sepsis, several episodes of pus collection and several surgeries, that anal sphincter function can get compromised, which unfortunately in most of the cases is irreversible condition. Well, perianal sepsis again is condition that we don't know enough about in terms of most of the population never have this experience. Some part of the population have one-off episode, but unfortunately there are patients out there who suffer all their lives. Unfortunately, there's no measure, there's nothing that we can really avoid or prevent or drop the risk of this condition to develop. Overall, we understand the healthy lifestyle, of course, a healthy immune system, and plenty of fluids and a reasonable fiber diet are the best ways to drop the risk developing the sepsis as much as possible. But again, clearly, these are our empiric recommendations. This is not something that would be proven scientifically. The important thing to know is that perianal sepsis is far much more common in patients with the Crohn's disease. It can be the consequence or clinical appearance of cancerous condition, and some patients with the ulcerative colitis can suffer more frequently of overall these perianal very unpleasant conditions. Having said that, we should always, as surgeons, we should always have this in mind, and if there's any concern or the patient don't respond to the usual treatment, such a patient should be investigated further by colonoscopy, mainly, sometimes even the MRI of small pelvis. Treating the fistula nowadays is a still very complex problem, and whichever meeting of colorectal is happening across this country or anywhere in the world, there's always discussion on this topic, because still, unfortunately, we don't have for our patients the treatment that would have 100% success, as I said, because we are trying to heal a spot in the human body which is the most infected, on and on and on. Usually the treatment needs to be split into steps. First step is called insertion of seton. That is the usually straightforward and very short surgical procedure that needs to be performed under general anesthetics. And the principle of this case is to explore the full track of the fistula itself, starting from the external opening and finding the communication towards the internal opening of the fistula itself. Then through this fistula, we put the very heavy thread of silk or other material that is not resorbable. This is a condition which is called seton insertion. The presence of the seton is surprisingly very well tolerated in most of the patients. The principle behind this is that the presence of the thread is avoiding to completely sealed off both or at least one of these opening, external or internal, and because that drainage then is permanent and avoids that cycle improvement, sealing off, bursting, and then to square one, then that healing can carry on, and the sepsis usually settles to the point of a very firm scar tissue. Usually the seton needs to stay in place with the somewhere around 6 months, sometimes longer. And when this perianal sepsis or perianal fistula is successfully converted to this nicely formed and easy to palpate scar tissue tract, then comes the second step of the operation, which can be done several ways, but the principle remains the same. The principle of every single type of this operation is to seal off or close this internal opening of the fistula, of course, which way the infection is being fed. And if this is successful, then the rest of the fistula gets healed quite quickly when cut off from that infection. This can be done several ways. Unfortunately, neither of the surgeries we offer, as I said, has the 100% success. One of the latest nowadays is the sealing off or destructing the fistula by using the firing, releasing the energy of a laser, which has success rate about 80%. That is again very small, very short, very well tolerated under general anesthesia. Second surgery most used is a procedure which is called advancement flap. The principle of this operation is to mobilize the healthy tissue of the back passage and by this flap cover the internal opening, so the principle remains the same. That is quite advanced operation that needs a lot of experience, and its success rate varies from literature somewhere between 40 and 60%, so not very encouraging. There are several other procedures that we can offer our patients, but as I said, unfortunately, none of it has a 100% success rate.